Whoa, sorry about that. Let me get started, is what I was in the middle of saying. All right, so we have folks in the room and folks on Zoom, so welcome to everybody. This is 2022's second Innovation Lab Speaker Series, and we're thrilled to have a friend and colleague, Rosin, who is the Chief Innovation Officer at Penn Medicine out in Philadelphia. And when the lab here at WashU started about 5 years ago, at some point I was having trouble remembering how we got introduced, but however we did, it was fortuitous. Because a lot of what Roy has been doing, and he's been doing his work for about 10 years, really was a model both in philosophy and process and how we think about it here. And so I'm very excited to bring him here, both to share kind of the work they're doing and then to have an ongoing conversation about how we here at WashU and BJC, both with innovation and digital health, can take some of these lessons and advance those technologies and approaches for our own ends. So Roy's a graduate of both Harvard and Stanford, and then moved into business. A friend introduced him to a small company called Quicken, it sounds like. And he built the Quicken business to the product that we know that it is today. And then also ran the innovation lab within the broader Intuit business. And really was one of the people that brought all those pretty amazing products to the market. And I think all of us have probably seen that in the financial services industry. So then he got interested in healthcare, was at the start of the innovation lab out in Penn around 2012, and he'll spend some time talking about that. So with that, welcome. Thank you for coming out to the heat wave in St. Louis. And thanks for everybody else making the trek, and we look forward to hearing your comments.
I think this one's, you guys do keep it hot here. All right. Well, thanks. It's really fun to be here. I've been enjoying my conversations with Tom for years now, not just those initial ones. It's really good when you're trying to do something really hard and trying to change big institutions that often don't really want to change. It's good to have partners in crime who you can compare notes to, with. I'm going to stand over the side here. That's okay. Just it's a little bit bright in the eyes. So what Tom and I talked about was a little bit more of a portfolio review on the digital health side. And I was trying to think about which projects I wanted to feature. So I'll give you a little bit of an overlay, and I will pepper in a little bit about methods as I go through. And as Tom knows, I'm very happy to be interrupted, very happy to be taken off onto audibles anytime and talk about absolutely anything. Of course, a lot of times when you present projects, you present the clean, polished, beautiful version. And we all know that what's behind there was super messy and ugly and didn't go exactly the way it's even being presented, because it's kind of hard to present the reality version. But I'm happy to talk about any of those realities that you guys want to talk about. So, I often like to start with this project. Let's see if I can get this thing going here. Uh-oh. It was working a second ago. No? Huh. It literally was working a second ago. Let's see. What do you think? I can also use the keyboard if I need to. Let's just use the keyboard so we can keep going. Oh, no, it's frozen, I think. Let's see. Oh, click on the screen itself. Oh, yeah, yeah. Excellent. All right, thank you, sir. All right, so redo. I do often start with this. This is a project from many years ago now, and that the timing is actually relevant. But when we were first getting started with more rigorous type of projects on care delivery, one of the teams that came to us in women's health was struggling with this problem of preeclampsia, so hypertension during pregnancy. And it was just a fascinating problem to us for a bunch of reasons. First of all, it was a huge problem. And I think we all know about maternal mortality in the country. This was the #1 driver of readmissions of women coming back into the hospital with all kinds of terrible things like strokes. It was 20% of maternal deaths at the same time, and of course, large across the country. And what was fascinating is not only is it a big problem, but the professional society and the research that had been done helped us understand what we needed to do. Like, it was very clear that if we got a blood pressure value sort of 3 days after discharge, and another one 7 to 10 days after discharge, we actually could keep these women safe. We'd be great. And the other thing that made it interesting is tons of people were trying to do that, and they weren't getting there. So we had set up these free walk-in clinics to get those 2 blood pressures post-discharge, and that worked for nobody. And then we said, well, maybe people want to know that they have a slot, so we'll do the free walk-in clinics, but also, we'll add really flexible scheduling so they know that they'll have a spot and it's free and they can come at any time, but they'll know it's their spot. That worked for absolutely nobody. We added follow-up phone calls, phone call reminders. Anyone want to guess on this one? Any guesses? Yeah. So didn't work for anybody. And it's just like, okay, we know what we need to do. It's not working at all. And so the way we always started projects is deep immersion. I said, let's go figure out what's going on. Let's get embedded. Let's get deeply embedded and follow them through the entire process from when they leave home, they come to the appointment, go through the appointment, after everything. And what you see pretty obviously, and this is where the timing matters, is these are young women and their preferred modality for communication was texting. And 8 years ago, texting was not an acceptable, allowed modality for communication in healthcare. So I said, well, that's really interesting. I'll keep that nugget, in my brain. We said, okay, if we can text with these women, I wonder if texting can be used to get the information we don't have and to act on it. Even 8 years ago, we knew that getting the information we needed did not equal an outcome, right? Knowing what their blood pressure was did not eliminate strokes. It was somebody had to actually act on it. This is why almost all the early predictive analytics things failed, right? Hey, I know 10 hours in advance with sepsis is going to show up over there, right? And guess what happened to the mortality rate? Nothing, even though you had this big window to act because nobody did anything. So who is going to do what, when, and how with this new information? So you also have to design the care model behind the information. So we said, okay, how about this? We know how to do the simple algorithm of knowing which women are at risk. We will engage them in a visit. We will give them a off-the-shelf Walmart, CVS blood pressure cuff, and we'll start texting with them, which is what we did. But this is where the techniques come in. We didn't know what to build, right? So normally you'd use software. You'd have some kind of system or platform you were using this for. But we didn't know what to build. So what we did was what we call fake backend. And the fake backend was a 4th-year fellow named Adi Hirschberg. And Adi was pretending to be the software that we might eventually build. So she was texting, pretending to be a computer program. And when she would get a response, when she didn't get a response, which is generally what happened, we could iterate and change it every hour, right? So when they're not responding, you start to add the woman's name. How about add the baby's name? Maybe we should see if you have a friend and we'll text with the friend for social support. Hey, maybe we'll change the time of day. You know what? How about a snooze button? We interrupted them at the wrong time. They're breastfeeding. Try 10 minutes later. Because none of this was hard-coded, because we didn't have to get any IS resources, it was all a fake backend. We could change it constantly, right? And that was the beauty of fake backends. So we went from 0 up to 65. Now we're getting 65% of the women are getting 2 blood pressures. 90% we're getting at least 1 blood pressure, which is off the charts. So now we had a sense of what to do. And so, okay, so now let's actually scale it. Let's move it onto a technology platform now that we know what to build, because we learned that with the fake backend. Right? So there's automated texting, automated responses, a platform we can monitor. A lot of this was medication titration, and so we had a backend designed. Continue to refine it, eventually run an RCT, and it was fabulous. Right? We went from 0% to 83% in terms of which patients we had those 2 blood pressures for. Again, we're in the 90s for one blood pressure. We eliminated 80% of the morbidity and the readmissions from hypertension and pregnancy. So pretty big breakthrough. We could actually count the number of strokes in young women that we're able to avoid. The unintended thing that happened, which was really fun, is we eliminated a longstanding racial disparity. So white women had always done better than Black women. And after this, and I can talk more about why this technology works, where other technology makes things worse, got it to the point where they both were exactly the same. So health equity, longstanding disparity eliminated. So when you do stuff like that, it spreads, right? So we have always tried to go from little pilot to go across Penn. And of course, we get really happy when it goes outside of Penn. This wasn't a company. It was just something we're doing with a lot of other systems, because we can now deploy it, in fact, on one of our platforms. So that's the idea of what we always try to do. Like, that's the kind of program, the kind of intervention that we like to create. And when I say we, who are we? Well, the Innovation Center in our world is sort of these 3 groups tied together, right? Acceleration Lab, which is the original group, which is about, hey, can we come up with new care delivery interventions? The Nudge Unit, which is sort of first in the nation, actually, in an academic medical center, where we're taking behavioral science, right, behavior change science, and we're implementing it in healthcare. And then the Center for Digital Health, which is all about new technology as well as big data sources. Can we extract value from these big data sources? And then on top of that, sort of the way we do things. From accelerators, which are sort of structured ways of getting ideas, of finding out who has thoughts, of moving them from idea all the way through the process to the other end to an outcome. Couple platforms, 3 platforms in the middle. Way to Health is this platform that we use for remote monitoring, staying engaged, staying connected to people even when they leave the system, leave the hospital, leave the clinic. Agent, which is sort of a wraparound abstraction layer for our Epic, for our electronic medical record. How do you get information in and out of systems really quickly? And craft things that doctors want, right? As opposed to what systems want. So if a doctor wants to know, I need to know anytime this happens. So what needs action? What needs attention right now? As opposed to sort of the alert fatigue you get in most of these where things and bells are going off all the time. The more clinician defined, here's what I want, when and how I want it, through whatever method I want it. It could be texted to me, it could be any way you want to get it. And then ways of collecting ideas, and finally networks. And networks means a lot of things. Networks includes how Tom and I are connected, right? Different innovation officers. Networks includes connections to venture capital. Networks includes networks of clinicians, because we can't get anything done without wonderful clinical champions. So networks means a lot of things, but like if you're going to be successful in any big institution or enterprise, healthcare or not, you need a very strong and powerful network. You need to be connected to lots of people and talk to them all the time. So platforms is a big idea for us, the ability to leverage things over and over again, get the marginal cost down. And so I'll give you an example of what I mean by that. So here's Heart Safe Motherhood, that one, the story I just told you, the first one. And after we did that one, here's what happened. We did a few more, right? And these are just algorithmic two-way texting. And after that, we said, well, you know what? There's actually a reason to get some AI or natural language processing going. So the ones in blue are that, right? So now, of course, here, like you saw here, like we know what to ask, or we know what we're going to get. Hey, I need your blood pressure. We know it's going to come back. So it's algorithmic. If this, then that. And we know what to do. We can automate all kinds of processes. Over here, in the when you're starting to use AI, and AI really just means natural language understanding, really. It means that a patient can initiate a conversation instead of us initiating. It means that we can talk about things that are a little bit more fuzzy, where we don't exactly know what they're talking about, but we need to figure it out pretty quickly. So all kind of things came out of that one. Most of these on just 2 platforms. All these projects are on 2 pieces of technology, right? So the white is pretty much, for the most part, Way to Health that I showed you in the last slide. The blue is, for the most part, pretty much one external partner, that we work with. And what we started to see was big results, right? So not only did we reduce 80% of readmissions and morbidity here, ortho, there's a lot more bundles going on at ortho. We're trying to keep people out of the hospital. We had a 75% reduction in readmissions in ortho with the same type of program. We start to move to automation around processes. So COVID Watch was our platform for keeping people with COVID out of the health system and out of the hospital. We were able to keep most people out. In fact, we just published last week how many lives we saved, which was really fabulous. But 87% were managed completely in an automated fashion. Only 13% needed a human touch, right? So we were able to automate a tremendous amount. And Refill Express up at the top, the 88% is specialty pharmacy, where we were able to automate 88% of the tasks that pharmacists were doing to, again, free them up so they could do other things. And then down here, once we realized that kind of automation operations, we started to take it into other types of operational type problems. And I'll talk about both of these. I'll talk about care and I'll talk about fertility. But this is like the percentage of new patient visits you can open up and get rid of. The 90% of on fertility is we got rid of 90% of the wait time to start with a specialist, right? It used to take 40 days, now it takes 4, right? So you can get rid of a ton of time when you're using this technology really effectively as well. So just to kind of evolve from this, let me focus on GI Penny for a second, just to give you a sense of what the AI piece of it looks like. So this was in a case where, a while ago, of course, these regimens, which are extremely complex and extremely toxic, they go home, they become home-based regimens, which is good for convenience in some ways, but of course, then the entire burden is on the patient. And because that burden of highly toxic, highly complicated things is on the patient, you get stuff like this. So you get about a 50% medication adherence. Out of a base of around 820 people for the time period I looked at, about 316 of them ended up in the emergency room. I mean, those are scary, scary numbers, obviously. And so we start to look at this and say, well, can we use the same kind of technology to go after this type of stuff? Starting with medication adherence. It's blurry, so I don't think you'll be able to read it. But we start to give them these, what they needed to do right then and there. And it was fascinating for me to learn about this stuff. I looked at the materials they used to hand out on paper, I've never seen anything more complicated because you have days on and days off, amounts changing, which pills you were taking were changing. These were really complicated. And even when we started to publish it and quote unquote simplify it, I had all these questions, like if you can read it, the last bubble says, wash your hands again after you're done. And I was like, why? Like, why do you wash your hands after you're done? Well, the same moment almost, I was asking that to the team, why you'd have to do that. Somebody came into the ER because they had put their contacts on without washing their hands and their eyes were burning out because these are highly toxic pills you're talking about. It's like, oh yes, wash your hands again afterwards. So you can see what the bot is doing here. And there's some fake back end, right? You are faking it before you make it. You have a human auditing, you have a human in the loop, it's often called. You have somebody back there who's helping define what the right answers are before you let it go into the wild where it can do its own thing more and more, which is the goal. So here, hey, here's your day one regimen. Let me know if you have any questions. Got it, no problem. So the patient's texting back. And then we go into symptom and side effect management. And so this is a case where they had some stomach pain and nausea. And what you're doing is you're mapping all of this language to intents because the answers you give are related to the intent. But right, the human language is fascinating, right? If you ask someone, how does somebody tell you they have a fever, right? I bet you if I asked everyone in this room, I'd get probably 10 different answers, right? I have a fever, I have a temperature, I have the chills, I'm shaking, I'm sweating, I don't feel well. There's like a million different things that people might say that all map to fever. So in this case, the bot's picking up, oh, they're talking about stomach pain, nausea. I think I know what that is. I think I know what to say, right? So it says, hey, try eating some high protein snacks. So why does it say that? We have years and years and years of data about how our oncology pharmacists, our NPs, and the physicians respond in all these different cases, right? There are these best practice pathways, and we're simply mapping them algorithmically onto what we're going to say here. So try that. Okay, let me see. Hey, it's also important to stay hydrated. Okay, yeah, I'm not drinking. I'll hydrate. How are you feeling? Much better today. I think dehydration is a big part of it. So you end up with these conversations, and these conversational threads got really long. They also got really interesting. They also got to the point where they had nothing to do about healthcare. People started to tell us, hey, I'm watching the Eagles. Hey, there's a parade going by my house, which is interesting and cool. So the good thing about it, and then the bad thing about it, the good thing about it is that you're creating something with almost no friction, right? You're creating a no friction interchange, which is phenomenal, right? You're also doing it in a way that has no UI. I'm a software guy. I spent my whole life building software. I happen to like software now that has no UI, right? Of course, I like designing UIs. I like building apps, but this is better than something that has a UI. The bad thing is you get all this information, you don't know what's relevant, what's not, right? So the fact that they're watching the Eagles, I don't know, maybe it's relevant, but probably not, right? And so how to use and digest and like, for example, what goes into Epic, what goes into the EMR, all these huge unanswered questions. So we start to see some really interesting things right away. You're having the system handle a lot of the incoming calls. I'll show you this at scale later, but even at small numbers, we were seeing really good things. And people were loving it. So the providers, what we did, since we couldn't automate, I don't want to trick anyone here. Since we didn't know how to automatically go through these threads, we had a human being auditing the threads, pulling out the things that we thought were clinically relevant and providing those to the physician. What was fascinating about it is that there was not only clinically relevant things, there were things that changed the course of care. And you can see the quote here. We got to this right regimen 3 to 6 months faster. A lot of times, patients would have symptoms that they never talk about. And maybe you had a rash and it was between appointments and it went away and you never mentioned it. So to be able to titrate and get to the right thing quickly, it was actually giving them information they needed. So first pilot was a tiny pilot, 10 patients, right? 10 patients. In those 10 patients, we avoided 4 emergency room visits in the first 10 patients. We're like, wow, this has potential. The adherence rate of those first 10, of course, it's thousands of data points with 10 patients. Adherence went from 50% to 98%. And patients loved it. We had a perfect likelihood to recommend score, decided to expand it to other things like lung cancer. And of course, then we moved up into bigger N's and bigger sample sizes. So we said, okay, how do you know when this is safe and you can let it loose without the fake back end, without the human in the loop? And so we're working on that now. And what we're doing is batches of 20 patients at a time, right? So 20 patients, can we get through 20 patients with no errors? Can we do it again? 20 patients with no errors. And we're actually coming up with a methodology of how to do it. The most interesting methodology part is probably how do you make the AI smarter faster, right? Because when everyone says AI, it's really all A and not I, right? It's not very intelligent. So how do you train it and get it up these curves as fast as possible? One of the things we did that worked really well was we were using Mechanical Turk, Amazon Mechanical Turk, and we would just farm out to all these humans out there at pennies each. Give us 20 different ways you might say this, right? So all the different ways you might say you had a fever, all the different ways you might say that you had a stomach ache, all the different ways you might say that you're in pain, right? And so we just use humans to be humans and talk. The way, Google has some of this stuff naturally with all the conversations going on Gmail. So we got up that learning curve. In fact, on a women's health version of this, we went from an accuracy rate of about 60% to about 80+% just by using Amazon Mechanical Turk really, really quickly. So I said, yeah. Yeah.
So you're going to do what? You're going to pick humans out with email?
Yeah. Yeah.
So tell me a little bit about how it's working.
Yeah. We do these things with our lawyers, right? The attorney is like part of the team. It's always a conversation about what's safe, right? And we always try to, as we're in the learning process, we make sure that we're doing it safely. So Tom, you've heard the story, so sorry, but when we were still in the early learning phase, one of the ways we kept it safe was we only ran it when we could have the human backend, right? So it ran like 9 to 5. And after 5, and this was one of the 4, when I said we had 4 ER trips avoided, one of them wasn't even the AI working, right? So one of the 4 was an after-hours person who said, my husband is really, really ill, I'm running into the emergency room. And so what we did after hours was an automated response. Hey, here's the phone number for the on-call resident, right? The on-call fellow, actually, right? And the story that I find that such an interesting story because we've had that on-call fellow forever. That's like not a new innovation, right? That person's been there, they've been reachable. No one ever calls them. Because what happens is if you are in that kind of shape that you need the emergency room, you go to the emergency room. You get in the car or you call an ambulance and you go. When you have a super low friction system, you might actually say, you actually tell us you're going to the emergency room, which like no one's ever done before. So at that point, they get this thing back that says, here's the cell phone for the resident, touch it, instantly connected to the resident. They're talking and they don't go to the emergency room because they can manage it at home. Legal is sitting there going, that's great. So you're only running it for now while someone's actually watching it. Fabulous. In the letting go, where the robots take over the world, Terminator style, it's a little bit different, right? That's where you get to a level of confidence, which we're not at yet, where it can run totally independently. And you're watching and you're watching 2 things. One is not only accuracy rate, the other one is how you fail, right? So think about it. Let's say I tell you I have an 80% accuracy rate, and we're actually above 80 now for a bunch of these. And you're probably thinking, well, that's pretty good, right? Most people think, oh, that's pretty good. Well, think about, let's just call it 80%. Let's just say we're 80%. The question is, what's happening in the other 20%? Because in the other 20%, you could boil it down to 2 basic things. One thing that's happening is it's saying, I don't really understand, you need to talk to a human. So that's an elegant fail, and that's totally fine. A different thing that could be happening is, hey, Tom, you should go drink bleach. That's not so fine. So the question is, how is it failing? Like most of these are not what's sort of out in the wild AI. So the answers are prescribed, right? And the AI is literally just matching the human word to an intent and then the intent to the answer. So you actually know the universe of answers. So, hey, Tom, you should drink bleach is not going to be in the universe of answers. But mapping to the wrong intent and therefore to the wrong answer is possible. So you have to go through that, and you have to go through it at a level of detail that legal is comfortable with, and then agree, as we were talking about in the last meeting, how good is good enough? What do you need to see? And not only legal, but actually, our clinicians have the same thing. Like Larry Shulman, who's a brilliant collaborator of mine, is one of the guys who runs the cancer center, said, I'm not going to be comfortable letting this loose on patients until I see several of these groups of 20 with no errors. So we have defined a method for deciding when it's ready to let them loose. And a couple of them are kind of loose now, which is cool. So I said I was going to come back to this one, and anyone interrupt me anytime. Tom and I, talking on the way over, like I don't even need to stick to my slides. I can go off script happily. So this is the one, if you remember, this circle is down at the bottom, where we started to realize that the same thing can not only automate aspects of health and make humans better off, but also could be really interesting from a system level and an operational level. And we talked about this at the last event because people were asking about value-based care and how does this stuff interplay with value-based care. And of course, value-based care sets innovation on fire because all of a sudden you have to solve for different things, right? And all your constraints are gone because as long as you get a good outcome, you don't have to worry about how many touches and how much work you do, right? Because you're not getting paid for volume, you're getting paid for value. So this is a case of breast cancer and breast reconstruction at Penn, where it had gone to a global payment. And we had a really interesting situation that I'll talk about in a minute, where we just couldn't get people in, couldn't get them in fast enough. So what was happening as a sort of a world center for this stuff, only 47% of people, less than half of people were getting in what we called fast enough, right? And if you have cancer in your body, that is the worst and most anxiety-producing weight of all time. So that was not acceptable. That everybody was coming to Penn, flying to Penn for this surgery, and we couldn't help them fast enough because the demand was above the supply. So as our teams started to look at this, they spent a whole bunch of time looking at what's taking up all of our clinic time. And what they saw was that these women would basically have 5 clinic appointments after surgery. So this 90-day global period, in that 90 days, there'd be 5 return visits. And they're all for really important things. They weren't like wasteful visits, right? So you're talking about drain checks, drain management, drain removals. Ultimately, you're talking about wound management, infections, looking for range of motion in the arms. You're looking for pain management. There's a bunch of clinical and non-clinical things. And the non-clinical was actually quite interesting too, because in addition to the clinical care, these visits were providing other stuff. They were providing empathy and education and reassurance, a hand on the shoulder, and those things we found out were important. One of the methods that we realized when you start to get rid of stuff, and one of the topics I love talking about, and happy to go off on this later, is deletion, right? Elimination, getting rid of stuff and then solving for its absence. So if you're going to get rid of clinic visits, as we're about to talk about here, you better know what those clinic visits do so you can solve for their absence, right? So they immediately started to work on the drain management because we didn't have to do that in clinic. That wasn't necessary. But the problem was we didn't really have anyone else to do it. And the nurses, the home care nurses, weren't doing it. They didn't know how to do it. They weren't comfortable doing it. They weren't sure they could do it. But the lead on this project was fabulous and said, okay, we can do this, guys. We will help. And I will get you to the point where all 3 of those visits are gone. And one of the things she did that's wonderful from an innovation story is this. She went to the local hardware store, bought a whole bunch of silicone and started making silicone breast models. Because what she realized is the nurses weren't comfortable, the home care nurses, they haven't never a feel for it. They never really practiced. Like, well, if you do it on silicone breast, it'll feel a lot like a real breast. So why don't we just start putting in drains and pulling drains and see what it's like? And so that's what they did on these silicone breast models that she made from the local hardware store. Right off the bat, the nurses were like, yeah, I can do this. Some of them had actually worked in the hospital. So like, yeah, I can totally do this. It's not that big a deal. So those 3 visits are gone. And then the next thing that happens is we start looking at the clinical ones, the non-drain ones. And there's a whole bunch of stuff going on in there. And that stuff is really perfect for these kind of digital tools. So you can see that we're looking at any changes, any pain, full range of motion. You want to look at make sure there's no infection going on. You can answer questions. So this actually, initially, we basically got rid of a whole nother visit, but in the end where it settled out is here, which is we didn't get rid of a full nother visit, but we took what used to be a 30-minute visit and we can do it in 5 minutes. In other words, we can do 6 patients in the time it used to take to do 1 patient. These are now just 5-minute quick check-ins because we can get almost all of it done on the technology at this point. So, and that includes things that are really the part of medicine that doctors don't want to deal with. You can, if your eyes are good enough to read, do you need any FMLA, any work release, forms management? Like that's just rules-based stuff. You can automate that stuff, right? So I love that. But here's the reason I chose this. I was like trying to think about which projects do I choose, and there's a lot, luckily, that we've done. The reason that this is one of my favorite projects of all time is that they redesigned the entire end-to-end, including the experience. So if you go back to what I said a minute ago, that's not just clinical stuff, but non-clinical stuff. When they spent the entire journey with these women from, again, home to clinic, back home, in their house, what's going on, they started to notice some things that were really tough, right? So it was really hard to drive. These women were trying to become independent again and be able to be independent women again. And like they had scars on their chest, and there's a really hard plastic thing called a seatbelt going right across your scar. So they built beautiful little soft seatbelt holders that made it comfortable so you could start driving again. Women couldn't shower alone. They needed help to shower. You have all these drains hanging off of you, right? And so they found beautiful like robes that had pockets on the inside that were designed by a cancer survivor, actually, and where you wouldn't feel like you had tentacles, because these women were like, I feel like I have tentacles. It's like, no, we can help so you don't feel like you have tentacles. And they actually looked at every single piece of this end to end, and it was beautiful, and it worked, and everyone was happy, including the surgeons. So that getting into the non-clinical, non-functional pieces, I think, is really, really important. These types of technology also enable a different kind of access improvement, which is the fertility circle, if you remember from the earlier slide. And this is what we call move the front door. And it's not a new idea. It's not all that creative, but we weren't able to do it without this kind of backing. And what move the front door means is that normally it takes a long, long time to get to the specialist you need. And in that long time, a lot of bad things happen, bad things for the patient, but also bad things for the business, right? They'll say, I'm going to go somewhere else. Your cancellation rates get really high, your no-shows get really high, your dissatisfaction gets really high, the expectations of what they get once they get there, if they've been waiting a long time, changes. We're like, we gotta start the care journey much, much, much earlier. So how do we start the care journey much, much, much earlier? We picked fertility on purpose because it's really hard. You have a man and a woman, you have lots of labs and lots of testing and lots of coordination. We're like, okay, if anything should show improvement from using technology to help with the coordination, it should be something like this. So here's your initial care journey, right? And what's particularly interesting, not other than it's long and convoluted and awful and complex, if you see the words missed opportunity, so missed opportunity means that was a chance to have a baby that they missed. So don't forget, people, when they come to you for fertility, have already been trying for years. So by the time they show up at the first step, they're already pissed off. Right? So they're upset at day one, not because of you. And each missed opportunity means that 30 days went by, right? And you missed another chance. And that is extremely upsetting to the people trying to have a baby. So, and you can see all the other things, workup testing and stuff going on. So two things. One, let's add an APP at the beginning, and let's use telehealth just to connect with her. And let's have another one of these. In this case, it was one of the AI-enabled bots coordinating everything else. And what happened was just fascinating. So basically, we went from this to this, right? And so we could do it within one cycle, basically. We could get everything coordinated. We, use the text space for the support in between. And it really comes through in the numbers, right? So in the end, I said 40 days to 4. In the end, we measured it with real data. It was 36 days to 4 days, 88% reduction. I love this one. And any of you who have been dealing with labor shortages and other problems, right? About a quarter of our patients were really confused and had lots of questions that we hadn't answered well and had follow-up things they were asking us about. So your inbox is exploding, your follow-up questions, your phones are exploding to 0, right? So the bot was able to handle all these questions without the staff in the staff time. So this 50% decrease in time to a complete workup when you have a plan meant that you went from 3 cycles basically or 2 cycles to 1. You could you fix your no-show and your same-day appointment cancellation rates. And of course, the combination of stuff is creating all this new patient capacity, right? So it's the using technology to create a new care model. Move the front door again, not brand new. A lot of people do this, but lots of things change, right? Hey, I used to have wasted appointments because people would show up without the work done that I needed, and then I need another appointment. It's just silly, and we've all seen that, and we all know it's silly. But this kind of technology and digital experience can fix that, which we kind of shown now several times. I was going to shift over to an inpatient example, just so I could give you a different side of the house. You want me to pause for questions? For anyone have questions, thoughts? Yeah. Yeah, we often test. We don't always assume that. And again, this is where some of the innovation techniques come in. I actually remember when we designed our first telehealth solution, gosh, 10 years ago or something it was, pretty much when we started the center. It was called Pen on Demand. It's called Pen on Demand now. And we actually didn't know what people would prefer. And we were basically considering phone visits, just telephone, video visits, and two-way texting. And in the classic way of, if any of you are familiar with the term vapor tests or smoke tests, right? We did a vapor test, and all we had was phone. We didn't have video or text, right? And so we offered all 3. We had a screen, just pull up your phone, this little, web-based app, and 3 big buttons. Do you want phone-based, video-based, or or text-based. And if you hit video or text, it would say still under construction, right? In other words, we were testing what did people want, and it ends up that most people wanted phone in that case. So we try to have these really fast and cheap ways to test what is the preferred modality. And then of course there's some logic behind it, like, okay, if it's a question that needs to be answered, we need two-way and generally async, right? Because the amount of different projects over the years where people say the words phone tag to me are like through the roof. We got caught in a game of phone tag and I had to call 18 times, and like, okay, how about asynchronous communication? You know, so generally we think about what's going on in that particular case. So again, hard to pick which inpatient one, but you know, Mend is so interesting to me because it combines some of the predictive analytics and algorithmic work with a care model change, you know, and one of these squeeze the balloon problems, because people have been working on length of stay for years and years and never changing it. They'd fix something and then they, you know, but they'd squeeze the balloon and the air would just move to a different part of the balloon. And ultimately there was regression to the mean and all kind of other things. And so this was actually, I have to give credit to our last CEO who said, you know, I've always believed that if we take care of people's mental health, we'll see it in other areas. We'll see it in physical health. We'll see it in throughput. We'll see it in other things. And I had an absolutely extraordinary clinical partner. All of these, I had extraordinary clinical partners. Like none of this happens because of the innovation team. Let's be clear about that. If you don't have a clinical champion, you're dead in the water, right? So it's only because we had, you know, clinical champions who were pulling and spending time and guiding us did any of this stuff happen. But this is a woman named Cecilia Livesay, who actually became the national lead of all mental health for United Healthcare after she did this and did some other cool stuff with us. So, you know, we got to work on this one largely because it was about 2019, I think it was, when we did this analysis on psych consults. And, you know, we saw in this one hospital about 1,000 consults, and we sort of knew we should have seen about 10x more from the calculations and some of the data that we had. And so we said, oh, that's not good. I think we can probably do better. And then we had the CEO in our ear about, you know, the hospital's full, and we need to get people out of bed. How about this approach? And so, you know, what we noticed with these people who had mental health issues, they were staying with us about 22% longer, which is an extra 30 hours, right? And like, okay, so I wonder if we can actually move that. What we started to do is, can we identify these people when they hit the floor, like the moment they hit the floor, not during their stay or at the end of the stay for referral to some kind of, you know, behavioral health program, but can we find them the minute they hit the floor? This was a free text analysis on notes, right? And they started to do a machine learning activity on these notes. And we find it and we find it and we find it, and got to a point where, yes, we in fact could find these people. And we found a lot more people than we had been finding, like a lot more people. And I'll show you that in a minute. Some of the things were pretty obvious. You don't really need a computer to help you with, like if someone, you know, depression, suicide, not a big surprise. Some of them were a lot less obvious that were predictive, like non-compliance or use of words like consequences. You know, maybe that this person doesn't understand consequences. I don't know what the actual text was, but it ended up being meaningful. You can see one of the platforms. Remember I talked about platforms that you can reuse. Agent was a way we could take data, manipulate it, get it in and out, and analyze it really fast. The essence of it was this triage, this algorithmic part where we actually split. It used to all be MD, so psych consults were all physician-led. We had a feeling that there's a lot of things and nuance going on, but they don't all have to be physician-led. But there was a question: can you get the right issue to the right person at the right time? We had a lot of work to do there, and it ended up breaking down into MD, NP, and social workers. You know, a lot of internal communication, other pieces of technology coming into use. That's one that we licensed. It's just a secure texting platform. And then getting them out, right, to the next step. So what happened is we went through this process of, you know, kind of iterating on these pieces was pretty amazing. So we started finding 8x the number of patients, and we saw them on day one, right? So that was a huge change to actually find everyone and identify the ones who needed help, and at the beginning of their journey. We had about a 4x increase in the number we were able to care for. This was huge for economics, right, to be able to deploy the model. So like I said, it used to be all MD. Now it's only 23% MD. So you could actually split the majority, right, 80% off to NPs and social work. And it fundamentally changed the experience of our clinicians, because as you all know, our clinicians are under a lot of pressure. It's really hard to be a doctor right now. And so these were patients who were very difficult patients, right? Not because it was their fault, but they were occupying a lot of time, a lot of attention, and a lot of pain and suffering. Some of the stats that I don't cover here is we saw about a 30% reduction in the use of restraints. We saw a huge reduction in people leaving against medical advice. We saw a huge reduction in one-on-one nurse sitting, which also takes up your staff that you don't have to give right now. And the big economic win, right, was this huge change in length of stay. So the CEO was right. Like, if you take care of this stuff, you take care of it early, things go better and the person can get out sooner. That's millions of dollars, right? So you have a millions of dollars gain because you're handling it very, very differently. I was going to end on this because it's such a different one, and we are already partnering on this project. It's a different kind of project where the technology piece is also a little bit harder to find, harder to see, if you will. So this is Impact, which is in use at BJC, as I understand it. And it's maybe still my favorite project of all. It was one of the first ones we did. We started it 10 years ago. It's gone through 10 years of iteration, and it is now the most effective social determinants of health program in the world. And I'm super proud of that. But this is a woman named Shreya Kangovi who was just so inspired to help vulnerable populations. And she had been studying what's going on and all things that we all know now, but they were less talked about 10 years ago, right? So food insecurity, housing insecurity, abuse, addiction, all the things that health systems are just not all that great at handling. And she was looking at these old care models like community health workers that have been around for hundreds of years, but they never really worked. And she was trying to understand, like, how do I redesign this program such that it works? So, we have this problem where 5% of our patients are driving 50% of our costs. It's always true. We are increasingly on the hook for that. We don't have the tools to do it. Shreya's work, as she started to go off on sitting on front porches, and literally thousands of front porches, she did years and years of actual research. So before she was, doing this as a more of an entrepreneur, she was doing it as a researcher. And that time and space is hard. Tom knows this, I know this. Like, how do you have the time and space to do that much work, to do thousands of patient interactions to design something? That is tough. She was an RWJ scholar at the time. She had time to do it. We often will look for people with more time. We'll look to fellows. We'll try to find the little bits of free space and time that exists somewhere in the health system. But Shreya's passion was amazing. One thing I always say about her is I'm used to working with founders and people who build companies. And she was working like an entrepreneur long before I trained her on anything. She was doing these absolutely fast cycles of have a hypothesis, design an experiment, test it, iterate, improve it, do it again. And she would do that again and again and again and again. And ultimately, what she realized is you had all of these different ways that we systems were going after SDOH, from screenings to point solutions on transportation and whatnot, to different navigations and, nurse navigators and other things. And all of the time they were studied, there was either an absolute null effect or a small effect. And the second time it was studied, like in Camden Coalition, it was regression to the mean, right? They just did not work. And she's like, we have to do better than that. And that missing piece in the middle ended up being the community health workers, but not the way they had historically been used, completely differently. So she literally redesigned every part of it. And yes, they can, this is what they obviously are good at. These are people who, this is not like, oh, hire someone and call them as CHW. This is, what is a natural helper like? Someone who comes from the same zip code, who comes from a shared background experience, who has a different perspective, who can create engagement differently. Even if a doctor and nurse had time, they're not going to create this kind of bond, this kind of engagement. So, and of course, cheaper than other people on our labor force. And so from the very beginning to how do you identify these people, to how do you hire them, how do you train them, how do you deploy them, how do you manage them, how do you measure, how do you iterate, what are the techniques of motivational interviewing and plan making, of resources, that you have a network of resources at your fingertips that change things, how do you get someone resources when they need them. She redesigned every single element of this program and ended up at this crazy place, right? So she has now eliminated 66% of hospital days, of days these people spend in the hospital. That's incredible for the most vulnerable population. So this is why she is now, actually, I'll come back to a number on the screen, which is the cost. So this $2,500 savings per person per year, so Medicaid is saving net, or the system is saving net $2,500 per person per year. Medicaid is actually saving $4,200 per person per year. The difference is our cost to get there, the cost of the program, right? So $2,500 savings per person per year is the net savings, right? That is out of control. That's the $2.50 return for every dollar invested. One of the things that doesn't get nearly enough attention when I talk about redesigning every element of it is that normal turnover for CHW programs is 70%, and she's at 2%. right? So this is a fundamentally different approach, and it's just using innovation techniques of getting deeply embedded, developing empathy, understanding the reality of the world, not the way people tell you the world is, and doing those fast iterations. And so it's really, when I thought about, okay, what else could I say other than like really cool outpatient things and some fun inpatient things? This way of going after some of the biggest stuff that health systems aren't good at, particularly since you're already working with us, I'm really proud of this one. Where's the technology, since we like to talk about digital health? The technology, once you have this protocol, which is RCT based, right? And it's multiple RCT based, right? Then you have this question about fidelity to the protocol, adherence to the protocol. How do we make sure that if you scale and grow and get it bigger and bigger and move it to different systems, this is in 20 different states now. This is way beyond Penn at this point, right? How then do you make sure it keeps working? Well, underneath is a piece of technology, right? And that piece of technology underneath is sort of adherence to the protocol. That's an evidence-based protocol. So it's a different use of digital to get where you want to go. So do I have a little time to keep going? Cool. All right. I think there's two more topics I wanted to hit. One was the nudge unit, and one was sort of overall takeaways. None of which will surprise you. So it's an exercise of stating the obvious. So digital does enable behavioral science, right? And I don't know if any of you are Freakonomics listeners, but we're very proud of our genesis of the nudge unit. So we started the first nudge unit in an academic medical center. And the beginning of the first project that got talked about was the one that was the title of one of the Freakonomics units, Freakonomics episodes. And the title was, how do you save $32 million in an hour? And so this is the story of saving $32 million in an hour. And what it was a change to our epic that around generic prescribing. So for years and years and years, we had been trying to get people to use more generics, right? It was for mostly cost, but also cost is related to adherence. So there's adherence as well. And each one of these lines is a drug, right? And this is the percent prescribed as a generic. So they're all over the map, right? Just noise. And if you took each one of these lines backwards, you go up and down and up and down and up and down. But basically what you'd see is it's flat. Each one of these lines, the rate prescribed as a generic is flat, despite dozens of interventions, training sessions, pleading, begging, screensavers, posters on the walls, other types of things that we would do. Nothing worked, right? At this point in time, a default was used, right? So the default now in Epic changed from, deliver as prescribed to, unless you check an extra box, it's going to become a generic, right? So you could prescribe whatever you want, but unless you did more work to say, I want this delivered as prescribed, it's going to become the generic, right? So it's not a lot of extra work, but we know that people do the least amount of work possible, right? So you generally want to make the default, the thing that you want them to do, the least amount of work possible. All right, so now we have this new checkbox that you have to check if you want it to be a brand. What do you think happens? Isn't that a beautiful graph? 97.5%, and stayed there ever since, right? So, we always say that change is extremely hard. Change is hard enough. Sustainable change is the holy grail, right? So when you have these structural interventions, you get sustainable change, right? Because it's built into the structure of the workflow. So, and the other thing that I point out sometimes, the straggler is actually proof that it works, right? Because this is paternalistic, right? You are manipulating people, if you will. And so the question is, what's going on? That's Synthroid down there, right? It's thyroid drug. And if you titrate on Synthroid and it's working, you don't necessarily want to switch to a generic, right? So that's actually a good thing that you have a straggler, not a bad thing, just to be clear. So how do I talk about this at Penn? I'll give you two quick non-healthcare stories, and I'll come back to the nudge unit. The confusion, I think, about nudges, I'm glad Thaler won his Nobel Prize. He's amazing, and the overall theory of knowledge is amazing. They get too caught up in the essence of the nudge itself, right? And I just talked about defaults and how powerful defaults are. Right? Default, it would be the nudge, right? It's how information is presented changes behavior. And it's great. It's like, information architecture. You can call it a lot of different things. And it's true that how you present information does change behavior. But that's only half the story. Because the other part of the story that I always love to talk about is friction management. And if you think about the world as friction management, you will win. If you fail to think about the world as friction management, you will lose 100%. And there's a guy at Penn who, I can go off on a million tangents. I'll try to keep it to only a few. His name was Paul Rosin, but not a relationship. He did these experiments that showed the tiniest bits of friction change behavior. He studied these people who went to a salad bar, and I think it might have actually been a salad bar around Penn, but they basically took the same things every time for years, no change, right? And his experiment was he took the things in the front row and moved them to the back row. And after years of not having them change what they take, they took what was ever in the front row. They didn't reach an extra 6 inches to get the things that they'd always eaten and liked in the background, right? So people really do not like to expend effort. That water flows to the lowest point. So, okay, so why am I saying all this? Anyone here ever rented a taxi cab in New York City, before year 2000? A couple of you old enough to have done that. So if you tried to do that, there's one of two things you heard from your cab driver, right? It was either, I don't take credit cards, which was not true, or my credit card machine is broken, which is also not true, right? Why? We know why. They wanted to get paid cash. They wanted to avoid taxes. They wanted immediate gratification. There's a lot of reasons why getting paid cash was preferable to these guys, right? So around the year 2000 and into 2001 is when digital showed up, right? So now in the back seat, you have a little terminal, right? And as soon as you have a little terminal, once you have a digital interface, now you can have behavioral science, right? You can have defaults. You can have all kinds of different ways information is presented. So, you can see up here, now we have defaults, right? Default tip amounts. Don't forget, you can type in any tip amount you want. 18 cents, $7.52. You can type in whatever you want. But people do the least amount of work possible and social norming. People want to do what other people do. I want to do the right thing, whatever the right thing is. I want to tip whatever Tom's tipping. Tom, what are you tipping? I'll tip whatever you're tipping, right? I don't know the right answer, so I want to know what other people do. What's standard? So defaults give you both, right? And of course, we could talk about a lot of things other than defaults, but they're really interesting. So the average tip amount went from 10% to 22%, which was $144 million additional tips in 1 year, right? And all these cab drivers who said, no, I don't take credit cards. They're like, can you please put your cash away and use a credit card? I'd like you to use a credit card, right? So you talk about really difficult behavior change through nudges. Why do I talk about friction though? You'll see in a minute when I get to the nudge unit. So another one of my favorite stories, if you guys remember the just horrific earthquake in 2010 down in Haiti, right? It was the first time that some of the foundations and charities started to think about some of these things. And it was fascinating to watch them because, so you have this devastating earthquake, you have death and destruction everywhere, and you have the typical TV ads, right? And the normal way you'd have to do it is you'd have to go, if you wanted to act, if you wanted to donate money, you'd have to get up, go to your computer, log in or whatever, get to the website, find the donate button, click it, start to fill things out, right? Fill out your name, address, pull out your wallet, start to type that stuff in, right? So now you're typing in, your credit card information. It's about 20 steps. What they did here was said, hey, that's a lot of steps. That's a lot of friction. How about no friction? What if you just texted the word Haiti to a short code, right? If you texted the word Haiti to a short code, it would automatically take $10 off your statement. So $10 would be donated on your behalf, right? If you just did one thing. Pull out your phone, text Haiti, done. $43 million of additional donations from people who had no interest in Haiti or no relationship to Haiti. They were taking advantage of immediate gratification, right? So that's friction reduction, right? So there's nudges, there's choice architecture, and there's friction reduction, right? Why do I talk about both? So here's the story that Tom, This is our cardiac rehab story, right? And we were terrible. This is an evidence-based thing. It's 30% reduction in mortality readmissions. We were only using it 10% of the time we should have been. We were basically last among all academic medical centers. When we looked at the numbers, I think we were about the worst performer. When you guys don't like to be the worst performer, we don't like to be the worst performer. We didn't like that. So Mitesh Patel was a first nudge leader, and Sri Somali is another wonderful cardiologist who is in the nudge unit. Went after this and said, okay, let's go from opt-in to opt-out. Let's use a nudge. So instead of opting people into cardiac rehab, you're going to opt them out, right? And you'd think that's all you'd have to do if you just believe purely in choice architecture. But if you know about friction, you do more. And they looked at what was going on, having to know which patients are eligible, find a center near them, who could take them, who had openings, right? Filling out all the paperwork. There's a lot of steps. So they said, why don't we do a nudge and friction reduction? Let's do both of those two things. Let's automate, get rid of this work, and see what happens. So we went from last to first, right? So when we talk about nudges, nudge always sounds to people like small, like a little thing, but it's about leverage, where a little effort has a big payoff. That's what a nudge is really all about. This is massive leverage, right? So this is big, big, big change. So I think you have to think nudge plus friction reduction. All right, so here's my summary takeaway. I like my circles, so I keep using my circles. If these are just a sampling of projects that were successful projects that had good outcomes, and we did have a chance about actually right before COVID. And if anyone wants to talk about COVID, that's a whole nother story, and I'm happy to tell it. I even have some slides if you want me to. But before COVID, we had this chance to sit back and say, God, we've been doing this for like 7 years. We've done tons of projects. We have good outcomes. We have failures. Some things were off the charts. Some things didn't work at all. Like, what did we learn? Like, what's working here? And this is where the analysis, I think, is not going to surprise anyone. It's not going to be like, oh, wow, I never would have thought that. Like, I don't even think we have to do the analysis. But it was really, really interesting. Now, the one thing I won't talk about on the analysis, which was the underlying most important driver, is the successes are all where we had strong clinical champions and executive champions. Where we had organizational support and people, what I always say, people pulling instead of us pushing. I didn't put that on the slides, but that's essential. If I had to push, it was dead. If they were pulling, it would work. You got to keep that in mind. So clinical champions, executive champions, absolutely key. Other than that, 3 things. Who gets care? Who gives care? Where care happens. And so, who gets care? We have very constrained resources. So how do you use them the best and put them in the places where they make the biggest difference? The thing that I found really interesting on this one is that you heard this in several of the stories, right? Algorithmic real-time identification, like in MEND, 8x increase in finding the people who needed mental health, right? As an example. The story actually I was going to tell right before your wife left was palliative care, finding the people who are unlikely to be alive, right? And that data-driven assessment fundamentally changed doctors' thinking, right? Because doctors were not trying to make more money by keeping people in the hospital, doing another procedure and putting them in the ICU. They didn't want to give up on the patient. There must be something else we can do. And then they'd get this predictive analytics outcome, right? This person is not going to be alive 3 months from now, right? And all of a sudden they'd have a conversation about palliative care. It fundamentally changed their behavior in the use of both palliative and hospice care. So this algorithmic real-time identification to find people, we did this with opioids too. We had a 14x increase in being able to intercept people in the emergency room who had OUD. So algorithmic identification is a big deal for us. So making sure we're putting scarce resources on the right people. Who gives care, I think, is too often just thought of as top of license care, right? That's like the simple version. Oh yeah, we should do top license care. But it's a lot more than that. And what we started to see, the patterns that we started to see were number one, escalation patterns, like e-consults. We were doing this in rheumatology. Ended up that only 50% of the people heading towards a specialist needed to be there, right? They could either be managed in primary care. They really didn't need a rheumatologist at all. It was a different issue, right? So e-consults and escalation models were super effective. Automation, you heard that like several times, right? We can have the technology take over doing a lot of what the people are doing. So who gives care? Nobody. The technology is actually doing the work. That was that 87%, 88% of the tasks could be automated, right? When we were monitoring COVID patients, when we were having pharmacy technicians managing our chronic patients and their medications. So automation is a big part of that. And then novel roles, which is another reason I chose to tell you the impact story again. Community health workers. In the OUD space, it was certified recovery specialists or peer recovery specialists. When we used ethnic identification and peer recovery specialists, and you used a measure of success, which was 30 days after the touch point, was the person still in appropriate therapy? It was a 14x multiplier, right? So we had a 14x lift by using what would be called the novel role with algorithmic identification. And then finally, where, but not just where care happens, but also when. Where is usually, hey, move care from high cost to high value sites, out of the hospital into the home. I mean, that's pretty obvious, and I think people get it. But this kind of like find things earlier when they're cheaper and they're more remediable and you can deal with them easier. That's the other pattern that just keeps coming up again and again and again. You heard it, multiple times. You heard it with high blood pressures. We did it with COPD exacerbations. We've done it with just about everything. Sometimes we do need to change what can be done at home. Like, maybe people would laugh today, but when we started to do advanced heart care at home, actually in your world, like we didn't do IV diuretics in the home. So we had to actually create an IV diuretics in the home service so we could therefore move things out of the hospital to the home. So again, redesigning to be good. That's actually also true. I don't know which of the circles it's here, but during COVID or right before COVID, we had redesigned a lot of our cancer care to move home. And that cancer care at home, we had done for high value. We got lucky because when COVID hit and we had to have low touch or no contact care and you didn't want your cancer people coming in anyway, the fact that we had moved a whole bunch of regimens home was lucky timing, basically. So those are the lessons with the last one I talked about, right? Friction reduction, effort reduction. Clinicians can't add anything to their plates. You can't ask anyone in any health system to do more work. You can't. You just can't. And even little things like, oh, it's just one more click. Yeah, it's one more click on top of the 17,000 other one more clicks that you've already put in. We call this death by 1,000 paper cuts, right? And so you're in that death by 1,000 paper cuts world, or just another little pebble in the backpack. And then, of course, under effort reduction, relentless stakeholder management. You just got, not only do you need clinical and executive champions, you got to, every day you're working to rebuild and reinforce that support, because things don't get done in big institutions without a lot of people pulling in the same direction. So those are the lessons learned. I hope that's useful to you guys. And I'm happy to talk about anything that or otherwise. So thank you.
You mentioned building tech in-house as well as partnering with companies to solve these challenges. How do you determine which tech?
Yeah, so we do external scans, and if there's something out there that does it really well, I like to do that. Sometimes even if we think something's out there, but we want to we need to learn more, if we can kind of hack something really quickly to get a little bit more evidence, a little bit more confidence, we might hack it internally, intending to shift it to an external vendor if and when we get them through the vendor process, the legal process. But I say we try to stay okay either way, right? Like we try not to be not invented here, and we also try not to be only vendors can solve this. Vendors are scalable by their very nature. Sometimes cheaper because they're spreading their costs across you and hopefully lots of other clients as well. But sometimes we just find it's complex. You need lots of fast cycles, and if you are still in the phase of figuring out what you need, that's a good time to do it internally, because it's really hard to buy something when you don't know exactly what you need. So we do a lot of fast iterations internally to figure out what direction we go. If that thing then doesn't exist, we'll build it. And if it does exist, we'll buy it.
I'm curious, in an ANC, what are the strengths and weaknesses of doing this?
Yeah. I think the strengths are you have lots of brilliant people, lots of passionate, mission-driven people, and that's amazing. You have people who can help you think through what does it mean to have strong evidence, whether that's RCT or not, and that's really a benefit. You also have lots of trainees around, and some of which have a little bit more time. Sometimes they're not sleeping at all, but in certain phases they have a little bit more time. And we have med students on lots of projects and fellows, like I said, involved, because you really, no big institution has people really just sitting around with doing nothing. So finding the time to do stuff is part of the art of this. So those are a lot of strengths, and of course resources. We can do things that are hard for other people to do. The downside, is there certainly is some not invented here-ish thinking. I mean, one of the toughest ones that actually Tom and I talked about at a prior meeting is that faculty are only rewarded and promoted for doing novel work, which means that they get no benefit personally from adopting best practices. Like you can't write a New England Journal article or get promoted based on adopting someone else's work. And so awesome for front end of innovation, inventing something new, terrible for scaling what works, right? I mean, I told a story about taking something that was brilliantly done. I mean, maybe the best geriatric care model I've ever seen, and very, very effective and proven effective and really scrubbed and still proven effective, and not being able to get to another one of our hospitals because there's someone there who really wanted to do it themselves so they could get credit for it and publish it and be part of their academic career. So that's very hard, right? When the tenure track and the faculty promotion track is only based on novel things that you yourself did instead of how many lives you've saved or how much better the care is that you've delivered, that's a challenge, right? There's lots of other theoretical issues that depend institution by institution. Sometimes it's like, what does that AMC have their eye on, right? Because they all have such strong beliefs about we're going to be all about population health, or wow, look at Penn, we're doing great on immunotherapy and gene therapy and mRNA vaccines, and life sciences are going through the roof. So a lot of there's sort of a giant sucking sound of resources towards stuff that is bringing in hundreds of millions of dollars when in fact the engine is really care delivery. That's the $8 billion thing, right? So I think that there are challenges, but that's true of any large institution, right? I I think it's actually a gift to be at an academic medical center, you know. Yeah. Yeah. Right. Mhm. Yeah. A really awesome question. You know, like there's a couple different things I'd say. One is we really do try to reverse engineer what people are saying to get to the problem, right? Like one of the stories that I'll tell sometimes when I'm teaching problem definition is a true story from something that happened on my very first day of work. And so I walk in, I'm coming out of Silicon Valley. I know absolutely nothing about healthcare, not a shred was about healthcare. We had just run an innovation, and one of the winners, actually 6 of the winners, had all submitted the same thing. It was all about online scheduling. So it's basically open table for doctors. Again, this is 10 years ago, and a lot of systems do this now. And I love open table, and I love convenience, and I love being able to just go on and schedule myself. But I've learned not to make assumptions, right? By doing this as long as I've done it. And so I went around, since I had no experience, and I obviously couldn't do the observational research or contextual inquiry. I hadn't done any ethnography or anything. Your best friend is narrative, right? So it's the storytelling. So I had 6 people in front of me, and I went around the table. I said, "Tell me the story about why you're so excited about online scheduling." And you can probably imagine what they said, right? Like the first person's like, "Well, I need a dermatologist and I can't get in for 3 months." The next person said, "Well, my wife needs a neurology appointment. The next available is 11 weeks out." And every single one. And I'm just sitting there going, "So guys, what happens if we do online scheduling?" And they're kind of looking at me like, "Well, tell me what happens if we do online scheduling?" And finally, someone kind of raises their hand and says, "Nothing." And I'm like, "Exactly, right? Like it would be faster and easier to see that you can't get in." I don't think that was the problem they were trying to solve, right? So we went off and did load balancing. We did a whole bunch of other things that actually got you in the door faster. But that reverse engineering process is probably the first one. We are really lucky to have a data analyst, and it's an excellent data analyst that we've had almost since the beginning. And doing even just quick back of the envelope, like how big is this? Does this apply to one person? And some of those are really hard, right? Because it's like an orphan disease. Just because it only applies to a few people doesn't mean it's like seriously serious and something that really needs to be solved. And so that's a painful analysis sometimes. But you are trying to say, like, is this big or this big? Like how often does it happen? And even like, do we have enough volume that we can do something here, like that we can even learn, right? So some things are just better for multi-year RCTs, and some things are better for fast iteration work. But if you don't have volume coming in, you can't do fast iteration work, right? So we'll look at that stuff. We layer on the, do you have that strong clinical champion and executive champion? I don't care what priority, what they're talking about. If I don't have that, we're not doing it. The go stop. There's something I did at Intuit that worked extremely well, and I can't take credit for this. I wish I could give credit to the right person. I don't remember who made this up. I think it was either a guy named Joe Wells or somebody named Hugh Malazzi, 2 of my absolutely phenomenal colleagues at Intuit. But they realized like how bad we were at estimating like what was really possible. And in the old days, you'd have a problem in building software, building technology. You would get some estimates. So you'd have some engineers looking at it, do feasibility estimates, make some predictions, do schedules, start your work. And all they did was they made the change to, actually, why don't you work on the problem a little bit and then we'll talk about it. So they kind of flipped the order. And when you work on a problem a little bit first, it changes your understanding of the problem. And so we'll try to do that. In fact, we just did this in our latest cycle where we had a whole bunch of people kind of apply to work with us in a structured program. And we had opinions about go stop, but we didn't know what we were talking about. So somebody on my team spent 2 or 3 days with them, right? Or 2 or 3 hours with them even. It's like, go look, go embed yourself, go immerse yourself in that world. And it does change your perception of what's really going on. And it's amazing how often it changes the focus. One of the things that that I found really fascinating about this very last example is people have been asking us to do a lot more work on access. You know, it's an old problem, it's a new problem, it's an always problem. And as we went out thinking we were going to do these models around improving access, including like the breast cancer reconstruction model or the move the front door model, these are all models that improve, you know, access as well as improve patient care. The thing that kept coming up over and over again once they did that few hours or few days just sitting with the team was new patient record collection. Like I can't get the information I need to do what I need to do. And it's delaying care and it's driving my staff crazy. And, you know, team after team and like interstitial lung disease and in gyn-onc and in, heme, all these different areas. We went in to study something we thought was one thing and ends up being a different thing. And so like you do have to get a little bit deep quickly and just get your hands dirty quickly to see, is it really what, what they think it is? Sometimes we have the advantage of being a little bit removed. Like it's not that innovation people are not smarter than anyone else, but like it's almost like your ignorance is your power. You know, you can come in and ask these ignorant questions, and like if you're too close to it, it's hard to see how it might be different sometimes. You know, so there is a value to that level of ignorance at least. Thanks for having me.